Thank you. Hello, everyone, and welcome. This is Claire Thayer, Vice President, Business Development with MCOL, and I'll be your moderator. We're so very glad you could join us. Our webinar today is Making an Earlier Impact on Health and Outcomes. Why wait? Today's presenters are Aaron Benson, Director of Market Planning at LexisNexis Healthcare, and Rick Ingram, Director of Vertical Markets, Healthcare Payment and Delivery at LexisNexis Healthcare. Before we begin, we have just a couple of housekeeping items to cover. Our speakers will be taking your questions via the chat feature, and while all questions will be addressed at the end of the presentation, you're more than welcome to send in your questions now and at any time throughout the webinar. To chat, please click on the blue talk bubble on the bottom left-hand corner of your screen. We will also have 3 polling questions for audience participation, and will provide instruction for responses for each poll at the time of each poll. And lastly, if you require any assistance during the webinar, please contact the Healthcare Web Summit office, and they may be reached at 209-577-4888. Rick, we're now ready for you to begin.
Thank you, Claire, and welcome everyone. I hope you'll find today's content informative and helpful, but perhaps more importantly, thought-provoking. Both Aaron and I are committed to empowering the healthcare community with approaches that both support improved effectiveness and nurture innovation. We hope that today's somewhat one-way dialogue might lay the groundwork for continued conversations, and our direct contact information will be provided at the end of today's session. Within the time boundaries of this webinar, we've got much to share with you. Today's session is really all about driving a focus on healthcare dialogues with members or patients earlier through approaches that seek to better understand holistically a member's situation, not just medically, but across a wide spectrum of life's seemingly unrelated circumstances that, taken as a whole, can serve as the best possible early healthcare warning system. Our session is intended to challenge you to consider approaches and data assets that may have heretofore been ignored. Consider the following quote by Dr. David Erickson, Federal Reserve Bank of San Francisco, as he addressed the UCLA Fielding School of Public Health. He talked about shifting the focus from medical care to upstream social determinants of health, and observed, health happens in neighborhoods. Now, it's life's neighborhoods made up of insight points around access, success, failure, crime, safety, support, education, employment, family dynamics, just to name a few, that tell a story far deeper and broader than any Xerox health risk appraisal filled out in a physician waiting room can do. The challenge, can we use this neighborhood insight in a non-disruptive way to impact the goal of reaching the right patient in the right manner with the right information to deliver the right care at just the right time? Now, we'll kick off by putting a bit of perspective around the world of change that both health plans and providers are facing in early 2017, and share some insight into how social determinants of health approach might support fiscal sustainability. We will balance that with a word of caution surrounding patient or member engagement, but also provide some encouragement around new ways to communicate and relate in a hybrid health engagement culture. We'll then level set in definitions within social determinants of health. Hopefully you'll react like I once did, with a bit of surprise, skepticism, and uncertainty as you wonder what all this has to do with healthcare, let alone anticipating and paying health claims. From there, we'll share the importance of arriving at health attributes that are clinically validated and how best to operationalize those attributes into member outreach via scoring. As we wrap up, I'll help you step back just a bit to consider the myriad of issues and challenges or topics of common dialogue within the healthcare community. And I'll share my thoughts on how I see a practice of including social determinants of health as being a keystone to addressing more than just a few of these points of dialogue. Please don't be shy about posting questions, and we'll get to as many as possible toward the end of the hour. So let's get going. It's been a world of change for both payers and providers, whether it be the shift from fee-for-service to fee-for-value, where both the provider and payer community are working to align behavior with incentives, or perhaps more importantly, working to restructure business processes to live in the value world. These times have not been for the faint of heart. I would suggest it is time to take a break, sit back, and examine what can add value without minimalizing existing data sources. The blunt reality is this. When trying to re-engineer a provider's business model, or as a health plan, work with provider networks, a sustainable business model requires proactive engagement with a patient or member. Our industry can no longer await the first filing of a claim or await a patient to make an appointment with symptoms indicative of a diagnosis far too extreme, had we perhaps proactively reached out to members. Social determinants of health attributes enable the shift from reactiveness to proactiveness, and thereby financial sustainability. Dr. Donald Schwartz with the Robert Wood Johnson Foundation said, "We need to think upstream and differently so we can improve health rather than just improving the problems that were created by our society in not investing." Upstream, what does that mean to you? Could we, as a plan or provider, be ignoring an opportunity to make a difference at a different stage? If we were to focus on the social economic stages or conditions that our patient or member load is facing, could we make a difference via reduced complications or reduced costs or even reduced diagnostic severity? How would we manage or measure this progress? It's probably too simplistic to think of a patient engagement and equate it to an earlier appearance in the doctor's office. Despite the very best insight into social determinants of health, we must understand that even with the state-of-the-art engagement methodologies, we might be disappointed. We must understand three factors often driving a member's decision not to make an appointment for a physician office visit. First of all, the adage cash is king does reign. The concern about what something might cost and whether someone can afford that visit or what the out-of-payment might be or how the deductible fits in may drive a person's decision not to visit a doctor. Also, there's that old thing called, "I know something isn't right, but I'm not sure I want to hear it yet." Let's face it, when we do begin to realize that there's something physically wrong or something is more than just an ache and pain of growing older, we oftentimes internalize not reaching out to hear the bad news. And finally, why is my insurance company calling? Are they just trying to deny a cost? Why isn't my doctor calling? Why isn't my doctor calling? Trust with your doctor is sacred. Trust, even unfounded, drives decision-making every day. Even with the best data points directing a planned care manager to reach out to a member at risk, it may be more than we can reasonably expect. Which leads me to my final point around change. It's time to think and act as one. Why must we be payers and providers? If engagement yields greater positive response than when initiated by physicians, why not coordinate such insight from a plan to the physician? And as a provider suffocating in a fee-for-value new business model, why not gladly accept insight as to targets for proactive outreach? Perhaps as the models of payers and providers begin to increase in their number of shared performance metrics, members will actually feel that their support community is truly acting as one. Hence, increased consumer satisfaction and especially increased likelihood of engagement in one's own care plan and adherence. So now's the time to go to our first polling question. The question is, do you proactively contact members before a claim is first received? Choices are no, analyzing claims is enough. No, we don't have staff to support this. Yes, at least we attempt to. Or none of the above. So now that you've heard the question and the answer choices, I urge you to collect an answer and hit submit. We're going to give about 60 seconds for everyone to have an opportunity to consider where they are in their organization and how social determinants of health is being used to really proactively contact members. I think we'll skip to the results, so get your votes in 5, 4, 3, 2, 1. So, look at this, Aaron. Yes, at least we attempt to, 35%. But right behind is almost 20% of no, we don't have staff to support, and no, analyzing claims is enough, What concerns me is 28% and none of the above. I think the fact that 28% is talking about none of the above, I think it's a demarcation in terms of where we are as an industry. Healthcare has traditionally been lagging in using techniques of other industries like understanding a member. So when I think about the retail or the banking industry, I think about how they've long ago recognized that they need to understand the transactions in one's lives to create products that would be appealing to them. And yet in healthcare, we've operated in a silo between the payer and the provider, and reaching out to the member using information other than just claims, and using information because someone's already filed a claim or has already come to the doctor isn't necessarily second nature for us. What do you think?
I agree, and that's why I'm excited to be talking with everyone about social determinants today, because I really think it's going to change the game for how we can reach out to members.
And I think it's also important to note that there is a concern about having enough staff to support this. So I think we can talk about ways that we can streamline intelligence so that it doesn't seem to be overbearing. Thanks to everybody for participating in this, and let's continue. So just what are social determinants of health? Now, as promised, let's take some time to align definitions and discuss some rationale around both these determinants, as well as their applicability in improving health, by proactively using this information to engage members before claims are received. Claims that, on the face of their cost, procedure, and diagnosis, may indicate a seriousness not anticipated if we had not first leveraged insights into social determinants of health. Each of us live a life that corresponds to social, economic, and environmental factors. But too often this insight is not factored into a care management or outreach plan. Still, when combined into a singular view, how could we not want to reach out to members when we know that 1 in 3 deaths in the United States annually are related to social factors? And social isolation can increase risk of heart disease by 29% and stroke by 32%. And longitudinally, you have a member subsector that has undergone increased isolation. A member subsector is living in neighborhoods that have barriers to physical activity and access to health foods, hence they have a higher likelihood of obesity. Or considering that members without a higher education have a shorter life expectancy due to higher likelihood of smoking. 75 to 90% of primary care visits are due to stress. Little is wonder that members going through changes in income and work and family dynamics are more likely to have a higher stress factor. The real challenge is leveraging every data point available into not just a more comprehensive view of a member, but also a more comprehensive plan of care outreach. Erin, help us better define the kinds of data that contribute to this capacity.
Thanks, Rick. It's true. What you can learn from claims data alone is not a comprehensive picture of the individual. In cases where you have existing members or patients, such as with Ruth and Layla in this example, claims data does provide good insight into what care they may need. However, care recommendations need to be a good fit for a member's environment too, not just their medical condition. If recommendations won't work within the person's physical environment, aren't affordable or conveniently located, and are provided in a way that is hard for the member to understand, they won't be effective at improving health. With any influx of new members, as well as members switching insurers and providers, there will also be cases where claims information is not available, such as for Vivian and Alexis in this example. Social determinants of health can provide insight on where to focus care based on predicted risk for these new members as well. Next, we will explore specific social determinants of health areas. Per the World Health Organization, social determinants of health are conditions in which people are born, grow, live, work, and age that impact their health. The environment in which a person lives impacts their likelihood to develop health conditions, as well as their likelihood to effectively manage those conditions. The U.S. Department of Health and Human Services recognizes 5 areas of social determinants of health via healthypeople.gov. We will review those areas along with key data about a person available through our vast public record sources at LexisNexis that can indicate their health risk based on that social determinant. The first area we will discuss is health and healthcare. This includes understanding a member's access to care, including types and availability of medical facilities in an area, because proximity can impact how often it is used. For example, if there are not a lot of pharmacies in an area, it may be difficult for patients to adhere to their medications. The second social determinant area we'll discuss is social and community context. You saw before the statistics that social isolation can increase risk of heart disease by 29% and stroke by 32%. Data such as voter registration information can be indicative of how involved a person is in their community. Information on how close a person's nearest relative lives can provide insight into their support network. Other information on crimes, accidents, and sporting licenses can also indicate how a person is involved in their community. Economic stability is also a social determinant. Through information on a person's address stability, assets, and financial history, it is possible to determine if the person is likely to have financial challenges. This is important to know, not to limit a person's access to medical care based on ability to pay, but to help them address these challenges. Low income is a major contributor to higher incidence and severity of illness and earlier death. Many low-income people have difficulty paying for health care and medications when they struggle to pay for other essentials, such as housing, food, and utilities. The fourth social determinant area we'll discuss is neighborhood and built environment. This means understanding the demographics of the household where the patient lives, the type of housing they live in, and crime and income indexes of the area that can provide insight into the environment impacting the patient. For example, crime indexes of the individual's neighborhood matter because chronic anxiety about physical safety can have adverse effects on people's metabolism, leading to weight gain and conditions like heart disease and diabetes. They are less likely to be physically active if they don't have access to safe environments. The final area is education. This includes understanding an individual's level of education as well as areas of study. Individuals with lower education often have lower health literacy, which means poor health-related knowledge and comprehension. This can influence their ability to interpret medication labels and health messages. Studies have also shown they have increased hospitalizations, emergency care needs, decreased preventative care, and among the elderly, poorer overall health status and higher mortality. Looking at all of these areas of social determinants of health, it's important to understand that no one piece of data is enough to understand an individual. However, by looking at socioeconomic data on various social determinants of health, a picture of the individual emerges that can help personalize care for them. This personalized care is important for reducing expenses and achieving optimal health results. The AMA revealed at least 25 cents of every healthcare dollar is spent on the treatment of diseases or disabilities that result from potentially changeable behaviors. And, according to county health rankings, medical care determines only 20% of overall health, while social, economic, and environmental factors determine 50% of overall health.
This is fascinating, Erin, because I think it really drives home the importance of considering non-traditional electronic medical record data to understand a patient. I had a chance to hear Robert Wood Johnson Foundation present at a conference last week in Nashville, Tennessee. And one takeaway I had that really caught me off guard was an area looking at the state of New Jersey. And in a 6-mile difference from one point in the state to another point in the state, there's a 14-year change in life expectancy. The fact that you can live so close to each other and still have a shorter life expectancy because of all the socioeconomic factors driving social determinants of health really kind of accentuates the purpose and the importance of engaging patients earlier. It's going to be rare to see a health plan not redlining, which is not legal, go in and cover an area that covers 6 miles and have that kind of diversity. It's critical that when you sign up an employer group or you create a new health plan in an area like that, that you have that proactive capability of reaching out to the right people. Not that you wouldn't want to reach out to all of them, but a game plan to stratify that. So thanks, Erin, for this insight. You know, it strikes me that the art of leveraging social determinants of health is to be able to recognize statistically and clinically valid correlations. For example, how can we correlate the relationship between emergency room visits and annual income percentile ranks, and a crime index with average medication adherence? It must be more than just surfacing statistical rankings, both society's good and bad rankings with crime and income, with health factors such as medication adherence and emergency room visits. It is really about how the combination influences health and how we can use such information. If we had two members, Vivian and Alexis, without any medical claims history, would we engage them differently or engage them at all? The ability to personalize care based on age, gender, or zip code differences is limited. However, using social determinants of health, how might we approach Vivian if the social determinants of health factors presented Vivian with a socioeconomic health score of 83 out of 100, indicative of high total care cost? We'd probably place a high priority of exploring Vivian's circumstance in our outreach plan. Conversely, if Alexis presented a socioeconomic score of 20 out of 100 for low risk of total cost, we'd probably promote wellness programs for Alexis, but nothing more. So at the end of the day, the usage of socioeconomic data to consider social determinants of health for total care cost resulted in not treating Vivian and Alexis similarly, but rather very differently for statistically valid reasons.
Thanks for sharing examples where this data can be used to help determine what actions to take with new members. It can also provide insight into existing members. You will remember that Ruth and Layla are both existing members in this example with diabetes and peripheral arterial disease. It's tempting to provide them both with the same care recommendations, but social determinants will show a different story. Ruth's social determinants of health include high economic instability, low education, a high-crime neighborhood environment, and no nearby family support. These social determinants could lead to prioritizing her as a high priority for care intervention. Potential interventions might include payment plans or financial assistance programs and referrals to community centers and support groups. Addressing her medical conditions as well as her social determinants needs can optimize Ruth's health outcomes. Layla's story is different. Examining her social determinants of health reveals no high-risk indicators. Therefore, potential interventions might include general wellness and disease-specific management programs.
Thanks, Erin. I think it's time for another polling question. And the question goes like this: how well do you tailor care management and outreach based upon socioeconomic information? We don't do it at this time. We use some information to at least get us started. We hire a third party to interview new enrollees, or none of the above. It's a wide range of selections. I ask you to consider your organization today and determine if you're using socioeconomic information to tailor care management and outreach, the degree to which you're doing it. You don't do it at this time, you use some information, you hire a third party to interview on your behalf, or none of the above. I'll give you a few more seconds to select and poll. When you're ready, select and hit submit. So let's look at the results. Wow. 50% say we use some information. 27% says not at this time, none of the above, and 5% hire a third party to interview. I'd be fascinated in knowing what kind of the information and what percentage of the information we shared is being used today. I think we've already identified that it's very common to have in an electronic medical record a zip code, age, or gender. But we've also pointed out how really that doesn't even begin to scratch the surface in understanding the degree to which they need to tailor care management.
I agree, Rick. There were the 5 different categories, and demographic data, though it's important, only gets you so far. You really need to understand where people live and all of the conditions impacting them.
Let's continue on. Thank you for participating in this question. So, where are we? From the viewpoint of both the plans and providers, we've explored how industry challenges have led to the need to consider new insights into the lives of our members or patients, and how that might lead to insights into their health risks. How many of us were trained to factor this insight into patient care or medical claims management? I suspect few, if any, not that we don't recognize the importance. So, I would also not be surprised if many of you are skeptical as to how this insight might be factored into direct care protocols, care management, let alone new proactive methods of member or patient outreach. I urge you to approach this time of skepticism by following the following guidelines. Stay true to your medicine and training. There's no need to throw out existing care management protocols or reactive protocols when a patient presents with symptoms. But I also urge you to consider your discipline of health discovery. Why would you not want additional information that without claims or previous diagnostic testing could guide you in potentially being effective with limited hours in a day? And ask yourself how effective your existing data and analytics are in going beyond effective reaction to claims or patient visits. If 100% of your business model only rewarded proactive outreach for care management to avoid more severe condition care, would you demand more data for it to guide you to being proactive? Why wait? Why not now? We're bound to member claims load or volume and analytics around existing conditions based upon claims. There are times anything considered to be proactive must be seen as a luxury. But what if time and money were unlimited? How would you want to reach out to members or patients knowing that you could substantially impact the health and lives of only 1 in 3? Remember that 1 out of 3 deaths are a result of social factors. Perhaps you'd be well served in acting as if time and money were unlimited. We'd love that. After all, in risk-bearing agreements, the return such contracts offer, or the return on payer risk-based models, is based upon proactively engaging members and driving the success in any fee-for-value model. And it can be the differentiator. It is imperative to seek new methods to mitigate risk. When provided a comprehensive social determinants of health-based risk score, you have the opportunity to leverage just this kind of method to mitigate risk. Erin, can you help us link social determinant of health attributes and risk scoring for organizations facing the need to do things differently?
Thanks, Rick. So at LexisNexis Risk Solutions, our data science team has been studying and validating socioeconomic data to enable us to offer solutions to help healthcare organizations better stratify risk and manage care. Not all data is relevant to social determinants of health. LexisNexis has identified data that is relevant by clinically validating each of hundreds of attributes we offer against actual healthcare outcomes, such as readmission risk and medication adherence, using claims data to confirm their predictive power. Our attributes are derived from over 10,000 sources of public records data and linked to individual members using our unique proprietary linking technology. Public records data provides a foundation that is reliable and accurate, so our customers don't have to gather this information through surveys and can instead focus on providing personalized care. These attributes can be combined in models to better assess risk for members. Though these attributes do not replace the value of claims data, they can be powerful in the absence of claims data or as a supplemental data source to more comprehensively understand the individual. Social determinants of health information only furthers the ability of care providers to prevent complications down the road. Health risk prediction scores are also important. We provide these at the member level and leverage only validated socioeconomic attributes to provide a picture of future risk, which means you don't have to have claims data. Our total cost risk score predicts an individual's health risk over the next 12 months based on cost. And our readmission risk score, which is coming soon, will predict the potential for an individual to be readmitted to the hospital in the next 30 days.
I can't get over the fact that how fast we've changed in terms of looking at social economic data and understanding how the analysis of that drives the ability to anticipate the people that most directly need care intervention. But really, when you talk about readmission risk score, now you've really changed the game. It's a game changer because in addition to helping physicians with patients who have not yet presented and health plans deal with enrollees that have not yet submitted a claim, now by virtue that there's a readmission analysis, you're using existing claims as well to understand not only what kind of care they received, what procedures were done, but being able to anticipate the risk of readmission. Strictly from not just the procedure provided, but socioeconomic data.
That's right, Rick. Social determinants of health attributes and scores can help with prevention initiatives like we've been talking about, but it also can be used in things like discharge planning and follow-up care. These scores have shown to improve predictive accuracy over traditional demographic models, and we have plans to add new scores over time. Both the attributes and the scores can be used in risk stratification and care management initiatives, as we've shown through some of the examples, to help healthcare organizations better understand and manage risk among member and patient populations. Rick, to show what an organization can do with information on social determinants of health, I'd like to share what a leading company in the industry called EveryMove found when they used our scores. EveryMove offers a premier engagement solution for employers and health plans that transforms fitness tracking app information into financial incentives for employers and members. EveryMove compared LexisNexis socioeconomic health scores based on total cost to actual historic claims data for 5,000 members and validated the score's accuracy for overall risk and risk among 7 conditions, including diabetes, cancer, cardiovascular conditions, end-stage renal disease, musculoskeletal conditions, gastrointestinal conditions, and respiratory conditions. Members with the top 10% of socioeconomic health scores did show that they had higher risk than average, and prevalence of chronic conditions was higher among this population. EveryMove plans to use the scores to identify and engage the right people in health plans to take the right actions and improve overall health. We are seeing that the more organizations use our data to understand social determinants of health, the more value they find. As a healthcare community, we've only just begun to see the benefits from this exploration. So Rick, I think it's time for our last poll question. The question is, do you have any form of health risk score based upon clinically validated socioeconomic health attributes? The options, yes, but not necessarily clinically validated. No, but we try to contact all new enrollees. No, contacting all new enrollees is too burdensome, or none of the above. We'll give you a few seconds to respond to this. I think the clinically validated piece, Rick, we talked about this before, but I think it's really interesting because there's so much data available that you can almost become overwhelmed by the amount that you could pull from surveys and EMRs and things like that. And so we even went through and tested some and found that some of it wasn't relevant. So we really wanted to narrow it down for people to just that was relevant to health outcomes.
You know, and I think what makes it that more of a powerful impact is for years I've been involved with analytics shops looking at quality, cost, and care. And always when you're uncovering a relationship, there has to be clinical validation. There may be a statistically valid correlation, but unless there's a clinical validation that they are related, or there have been clinical trials or there have been studies, it's something that isn't relevant. And we've got to do something to take this massive amount of information and structure it in something that can be reacted to with a prioritization through scoring, but also know that it is validated. Yeah. So we've got the results.
Yeah, so there is some use of scores, not necessarily validated, about 34%. We're seeing the highest, though, in none of the above, which really isn't surprising. This is new data that's just starting to be used out there, and we're excited by the potential of it.
Yeah, I think, again, it's salient that this time is a perfect time for organizations to begin to recognize that this is a new way of controlling what they're being asked to control. If you're a provider at a risk contract, or if you're a plan that's dealing with new populations of insureds, this is time that you can actually take control and know that when you're making outreach, you're going to resonate with the member or the patient because you're talking about areas that apply to them. Thank you very much, folks, for taking part in these 3 questions. So let's keep going. I think it's clear that this can evolve into a critical component of improving health, improving care, and impacting cost. Certainly, we cannot afford to ignore socioeconomic data that can lead us to insight into those most at risk. I recently heard a quote attributed to Risa Lavizzo-Moret, the CEO of Robert Wood Johnson Foundation. She observed, "The choices one makes are determined by the choices one has." What a powerful observation. And I would argue utilizing social determinants of health to understand what makes up the kinds of choices one has is the approach that can help us both tailor more effective member messaging, but also really equip us to better react to those industry topics of dialogue I mentioned earlier. I think of it as the power to impact an organization across multiple concerns. Within the concern and trend of patient engagement and consumerism, why not reach out to all members when social determinant of health can outline those most in need? If your message resonates with the patient, wouldn't they be more satisfied? Around care payment models, don't value-based models require proactive patient outreach? And how can you expect to survive the transition from fee-for-service without reaching out to patients rather than waiting for conditions to drive them into your office? As we deal with care delivery models, risk-based agreements are driving new care delivery approaches. Salient to this are new approaches to patient or member interaction to proactively avoid more complicated medical care. A discipline factoring in social determinants of health is a game changer in engaging the member or the patient. As we talk and begin to address potentially avoidable conditions, early intervention can avoid more severe conditions. And as we look at the total health system performance, leveraging traditional care data, claims, electronic medical records, etc., with new social determinants of health data enables more effective patient interaction, which can lead to better care at a better time with the most appropriate members to avoid more severe conditions. The quality of member life can be improved. When we attack integrating mental and behavioral and personal health, every form of health is impacted by social determinants of health. A 360-degree view of health impacts intersections will impact every kind of health issue. And finally, when we talk about health data use and misuse, data at every life transaction point can be leveraged for insight into health risk. Health attributes must be clinically validated to ensure appropriate application and to avoid misuse. I've been fond of quoting many of my colleagues over the past 3 webinars I've done, but today I want to remind many of what I personally have been asserting, especially over the past 6 to 7 years. We must redefine healthcare data. If it is accurate and understood and can lead to conditions avoidance or improvement, it must be considered healthcare data, even if not found in the claims or medical record. I think we've got time for some questions, and we do have some questions posed, so let's get started and take a look at it. Let's talk, where do you pull the information for social and community context bucket?
That's a good question. So we pull all of our information from different public record sources. Like I said, we have over 10,000 different sources that come in. So some of the ones under social and community context were things like voter registration, so we do get that information. We get address information, and we're able to use our linking technology to link individuals to relatives, so we're able to then figure out how far they are from relatives. But all of this is coming from public records information that we bring in from a variety of sources, including court records and different government sources, as well as some of our internal derived sources as well. So what's interesting about it is because it is public records data, we have it on a vast number of individuals, and it is something that can be provided proactively without having to do surveys.
I think the important part is the routine updating of that and the accuracy of the data. Got another question around what socioeconomic factors were you surprised were not clinically validated?
Yeah, that's a good question, Rick. I don't have the full list of factors, but what I have found is that we really want to narrow in on the individual. So looking at a zip code, for example, you were talking about the 6-mile difference. And so taking any one of those pieces of information alone wouldn't necessarily give you that comprehensive view. There were certain pieces of information that were more useful looking holistically. So for example, whether someone had a car or not doesn't necessarily indicate it, but whether they have a vehicle overall and not just a car was found to be clinically accurate.
I think the important part about the science and discipline of the healthcare attributes driven from socioeconomic data, I'll use an example, and that is gun ownership. Licenses on file to have a gun in the home. And I'm not making a comment politically about gun ownership as much as, on the whole, that one factor would not necessarily be clinically validated for health risk. However, when taken in conjunction with the patient load that is also taking a prescribed antidepressant, where often suicidal tendencies are unintended consequences, and published when the drug is actually administered and published in the packaging, then it becomes clinically validated. This one intrigues me. Would it be fair to say that you can ensure that the data itself doesn't engender bias in choosing which services to offer to each member?
Yeah, I think that's an interesting question, Rick. So where we see the attributes today being used is in models. So you would load it into a model, and then that would help you to derive scores, or you can use the scores that we have derived, which can help with risk stratification and prioritization. Where we would see the individual information being used to help with care decisions would be rolling it up into categories like we talked about, where it's social and community context. So no, it doesn't need to be expressed to the physician that someone has a criminal background or what their exact financial situation is. You just want to give them indicators so that they can use that to make care recommendations.
And I think the question is a valid one, because I think as we go forward with this, what we're going to see is that the criticality of being able to take our clinically trained professionals and go through the process of what we call clinically validating social determinants of health. I think it's going to have to be from a customer to customer basis, so they become aware that behind the scenes there's very defendable processes, and the process is statistically valid. Yeah. We have another question, which is how do you deal with possible privacy invasion perception from members? That is a great question.
That is a great question.
I think the best way to premise this is, first of all, we're not hiding anything. This isn't something that is a cloak and dagger operation. However, within health insurers, as well as some of the more advanced provider organizations, for years, health insurers have been using methodologies to better tailor needs to individuals. And there are times when an insurance company reaches out to someone that the patient may be alerted or alarmed that there was something done. But I think, from a standpoint of privacy, this is all public records. This is information that is available, and that the clinical validation process is not public record as much as it does drive a reason to reach out. It's important to understand that we are, as a company, both not just LexisNexis Risk Solutions, but our parent corporation, we have the greatest respect for the data that we control, and we make sure that we go through all the protocols of security around misuse and use. So we feel comfortable in that. In fact, when I would argue that given the fact that our number one asset is the massive amounts of data across all industries known to man practically, if there's one company that you can trust with that privacy factor, it would be LexisNexis.
Yeah. Did you evaluate economic risk factors for mental health and substance use disorder readmission? So this is a great question. We haven't necessarily tested everything against every condition, but we have found that social determinants of health do have some correlation with substance abuse, with medication adherence, and with mental health in general, especially in terms of stress and anxiety and depression.
I think what's also happening is there's been, as I mentioned, about integrating behavioral mental with personal health, there's just the overarching understanding that this is a discipline that is ripe for more advancements. It's interesting, Erin and I, when we first started talking about bringing this to market and what the values were, I talked about, I've always been amazed when I hear a social worker, whether it be for health-related benefit plan or any other benefit plan or community outreach, their extreme training in asking questions that are designed at trying to uncover some of this publicly available information. And also when I think about the disciplines of mental health and behavioral health, whether it be substance abuse or more severe mental health issues, the nurse manager almost acts as a social worker in their training in terms of getting down to the underlying root cause. And so I actually think this is a discipline that is ripe to be merged into personal health. And at some point, when I see accountable care organizations struggling with surviving in a risk-based model, I actually think you're going to see some patient liaison staffing roles come up where they're really trained to this. So
yeah, we've already started to see that, where they're creating health coach roles and specifically to deal with social determinants.
It's great. Do you also incorporate individual survey responses into your risk models? That is not something that is not possible, but I feel like if we do that, in some ways we're losing the value of what we offer. there's nothing wrong with individual risk-based surveys. And certainly there are many corporate companies out there that will take your patient load, your member load, and make phone calls 2 or 3 times trying to reach through to capture some questioning that I touched upon. But when you think about what we're doing with the public information, we're actually kind of speed warping past that process and giving the ability to make a more tailored outreach to the individual. So then the questions are more tailored to the individual, not the same old 12 questions or 25 questions that you're giving everybody. Hope we did well on that. Hope we helped
well,
on
and
that.
I think for organizations that have additional survey data, they could, of course, combine that in their own models with our information. That's what's great about what we offer.
Is your risk score only socio-based, or do you incorporate a clinical risk score with your risk score?
So our risk score is only based on socioeconomic data that we get from public records. It doesn't include any kind of clinical claims information. So again, it can be used on its own if you don't have claims information available, especially with new members, but it also could be added to any kind of clinical models that you have if you do have claims information.
Right, that's great, Erin. You know, it's interesting because we've had some great questions. I don't see a lot more. Let's see here. We're scrolling through questions that we're looking at. Why can't we just use the claims information to do this outreach? I guess what I would say is, yes, you can use claims information, but then you're waiting, 1 month, 3 months, 6 months, 12 months before they may have even filed a claim. That doesn't mean that the lack of a claim is indicative that there's not a stress factor to be concerned about. So I think given the lack of socioeconomic data buried in a claim, you're far better off taking this as a discipline to augment and improve your processes. Why is this necessary? We have an excellent care management team. I couldn't agree more. That certainly is something that organizations should be proud of. And to be honest with you, I've never met a care management team that's not interested in having more information. I think that's what really distinguishes a top-notch care management team. They're always looking for an added edge, an added ability to have insight so that when they do engage a member, they're being more empathetic with the situation that presents itself, but also has that score in the back of their mind so they realize that if they call Rick Ingram, for example, and I said, I'm fine, I'm doing this, I'm fine, but all the socioeconomic data might indicate otherwise, it gives them a reason for perhaps asking a few more questions or taking an extra 5 minutes when they might not have with just the canned answer of someone who doesn't want to deal with the issues. So I think top-notch care management teams want more information.
I would agree with that.
Let's see. Do you use artificial intelligence to enhance your risk scoring for a given subpopulation? At this point, we are using standard public record information, standard clinical validation and modeling. It certainly could be a topic, subject for artificial intelligence, but that's not the way we're approaching it. I think the problem with that is you at some point lose clinical validation, or you run the danger of losing clinical validation. And at no point do we want to factor out the medical community. I think we've had some great questions. We've got a little more time left, but at the same time, I don't think it's worthy of just using up your time and being disrespectful. We've got one more, and that is, what does the outreach include when you have the social economic score?
So I'm not entirely sure what we mean by outreach here, but I would say with the score, particularly what it's helping you to do is to rank order in terms of who is at highest and lowest risk in your population. If they're falling into the higher risk scores, they're more likely to have some kind of chronic condition, and you may want to enroll them in your care management programs or be more proactive about the outreach. But a lot of times it's using your traditional care management programs. It's just helping you to figure out who really needs to be targeted with those programs so that you can get to those with the highest needs earlier.
And I think, years of predictive modeling in terms of who reacts best to what mode of intervention or outreach. Certainly you have the opportunity, particularly with a severe risk score, to have a nurse case manager make a home visit or reach out in ways that may be more aggressive when you have a higher risk of having an adverse reaction or something down the road. We've got a couple more coming in.
So this next one's interesting. How do you recognize the individual member, and how easy is it to link your member data with our membership data? So this is really where LexisNexis is. It's our core technology. It's what we were built on. Is we have something called a Lex ID, where we build profiles proactively on, I think, like 270 million individuals in the United States. And so then if you send us just basic information on members or patients like name and address, we're able to use our proprietary linking technology with, I believe, over 99% accuracy to link them to these different pieces of data. So it's definitely an important part of it is making sure that we're giving you the right data back on the right person.
That's a great point, and I think it's something that's becoming more and more salient as the topic of national identifiers begins to raise its head. I just saw one that I think, here we go. Do you see social determinants of health information becoming an element required in all payer risk contracts? Boy, that is a great one. Putting my finance hat on, I think it would be a great term within a payer risk-based contract. I don't see that happening per se because I think particularly this next, we'll say 12 to 18 months, you'll have a certain number of providers that will push back on being told what they must consider in terms of delivering care. But understand that the purpose of a risk-based contract is who bears the risk. So the real question I would say is, at what point does the medical community, either through the AMA or any other association, begin to conduct seminars, webinars? We certainly can do this kind of thing in terms of helping organizations who are in a risk-based performance contract understand why it's important to include those other things. It shouldn't be a requirement because I think that reeks of a payer perhaps dictating of how to deliver care. But when you are tied to risk and the financial solvency, sustainability issue comes up, that's when the appetite's going to be more ripe for wanting to include social determinants of health. I see another one. Is there any reason you're not using paid data sources such as coming from the credit agency such as Experian? You know what?
We actually get paid data sources as well as government-provided data sources. So again, you've got 10,000 sources feeding into it. So we actually have more information than the credit bureaus on what we would consider underbanked members of the population where they have thin credit histories, but we also get credit information.
Yeah, it is an added ingredient to the database, but relying upon just credit information really doesn't allow you to do the kind of degree of depth of modeling that we do. I think that's about it. We've got just 5 minutes left. I'm not sure that we've got any more. If you have a last-minute question, please shoot it out, and we'll be happy to try to answer. Here's one more. What is your hosting model for sharing the information? Is this hosted at your site or at a customer site?
Yeah, so this is a good question. So we provide the data, but it is platform agnostic, which means that you can load it into any system that you have.
Is your solution only in the U.S. or also in Canada?
So currently it is limited to the U.S., although we're always looking for opportunities to expand, but currently it's limited to the United States.
It's interesting. I might also add that there have been some studies around megalopolis areas. It was originally in looking at cross-regional boundaries for exchanges, but there has been a certain amount of validation that areas like Toronto, right across a thin border with the United States, can benefit from the insight from that local area right next to its border. We're not at the stage where we could even begin to clinically validate that. And it would also change in terms of total cost because it may include a different kind of cost parameter by procedure. But stay tuned. It can be on the horizon. We're down to 3 minutes, and I think we're going to go ahead and draw it to a close. We appreciate your questions, and we hope that we've done them justice and answered you, but please don't hesitate to reach out to us. Erin and I appreciate your time and attention and very much look forward to discussions with you as you work to better understand your new plan or book of business enrollees through the use of social determinants of health data. Please don't hesitate to reach out to us through the contact information on the screen, as well as visiting the site links provided. As Bob Dylan once sang out, and as many in the healthcare will attest, the times they are changing. Erin, I, and all of us at LexisNexis Healthcare are thrilled to be part of this change. This now concludes our webinar. Thank you, and have a good afternoon.